So, welcome back to another video on peripheral neuropathy. It's a clinical approach. I'll be talking about the approach to peripheral neuropathy. So, in this video, the basic layout will be a demonstration of the different patterns of peripheral neuropathy and how these what is pattern recognition in peripheral neuropathy. There are actually 10 patterns and I will be discussing each one of them in detail. So this video is going to be a bit longer, but definitely it will be very interesting because usage of this pattern recognition can help you identify the cause of the peripheral neuropathy, and which will be very important in your clinical practice, right? So as in the previous video, we'll start with a case, right? So here is the case, right? So this gentleman is a 45-year-old male who is having a chief complaint of weakness of both the lower limbs, right? And there is frequent falls, right? There is diminished sensation of bilateral hands and feet, and there is increased fatigability. Now, from this, we have involvement of the motor system because there is weakness of bilateral lower limbs, and there is also diminished sensation, that is sensory system. So how this is important, I'll be talking about, because this is actually a symmetric motor and sensory neuropathy. So it is a symmetric motor sensory weakness, okay? And the faults are increased in the dark, that suggest that his proprioceptive sensations are not there. That's why in the absence of visual feedback, he is having increased faults. And there is swaying to the side to side, again that suggests ataxia, and that is due to this sensory ataxia. And the faults are both forward and backward, right? Now on examination, on the general examination, we found pallor, which explains this increased fatigability. There is hyperpigmentation. I'll be talking about why there is hyperpigmentation in this case, and this tachycardia probably due to anemia. On neurological examination, the mini-mental status examination revealed a score of 24 out of 30. On cranial nerve examination, the only significant finding was the presence of optic atrophy. Rest all cranial nerves were normal. Motor system examination, there was a power in the lower limbs of 3/5. In the upper limb, it was 4+/5. And the tone is increased. There is hypertonia in both the upper limb and lower limb, suggesting corticospinal tract affection. The deep tendon reflexes, that ankle jerk, is absent, and bilateral biceps, knee, and the triceps are normal. But if we look at the sensory system, proprioception, vibration, joint position is lost, which actually confirmed our history. Actually, it confirmed our history that this patient had got diminished sensation because this pain temperature, the lateral spinothalamic tract. Actually, this is a small fiber neuropathy. I'll be discussing what are small fibers, what are large fibers. So pain and temperature are carried by small fibers, whereas proprioception, vibration, joint position are carried by large fibers. So these are actually large myelinated fibers, right? These are small unmyelinated fibers. And this diminished sensation in bilateral hands and feet actually signifies small fibers. But this one, increased falls in the dark, swaying to side, actually means large fiber, right? And this plantar is bilateral extensor, and this Romberg sign is positive, which is very typical of a sensory ataxia, right? Now next is what to do next. So how do you proceed in this case? So basically, before discussing about this particular case, I'll be talking about the divisions of the neuron, right? You have this neuron, you have been reading this fundamental neuron since your undergraduate days. So, this part is known as the cell body, and this is the axon. So, as the name indicates, this is any disorder which will affect the axon will be called the axonopathy, and anything which affects the myelin will be called a myelinopathy. The name for a, since these cell bodies are present in the ganglions, so the name is ganglionopathy. So basically we can divide them anatomically into axonopathy, myelinopathy, or ganglionopathy. Now, this was what we revisited in the previous case. We told that there are basically three systems which can be affected by peripheral neuropathy. One is the motor system, and the sensory system, and autonomic system. And this is based on the enlarger Gasser classification of the nerve fibers, which we know that A, B, and C, right? Now we all know that the A fibers are again A alpha, A beta fibers, A delta, A gamma, and A delta fibers. So A delta and the C fibers are actually carrying the pain, and this A alpha is actually the large fibers. They are actually motor fibers, and they are large myelinated nerve fibers, and that's what was affected in the previous case, the motor system. The sensory system is actually divided into large and small. Large fibers are carrying the vibration, proprioception, whereas the small fibers we have already discussed carry the pain and temperature. The autonomic fibers are actually, they have been classified midway, they are actually B fibers, and they are small fibers. Right. Now, whenever you talk about peripheral neuropathy, we actually talk about 7 key questions. So, what are the 7 key questions which need to be answered in any case of peripheral neuropathy? The first key question is to be answered is which systems are actually affected, whether it is the motor system, whether it is the sensory system, or whether it is the autonomic symptoms. So that you can get an idea from the history. Now, the motor system, suppose a motor, your answer in this first question is suppose motor system is affected. Now you need to know whether it is symmetrically affected or it is asymmetric, like one limb is affected, other limb is normal, whether it is only focal, it's a single limb is affected, single group of muscle is affected, or it is only proximal, like say thigh muscle weakness, or involvement of the arm muscles, so that is proximal muscle weakness. Now distal muscles, so distal muscles will be like your leg muscle weakness of the wrists, so that will be distal muscle. So how do they present actually, how do you know? So you actually ask for proximal muscle weakness in the upper limb and in the lower limb. So in the upper limb, basically the patient will complain to you of difficulty in carrying out overhead abduction, difficulty in combing the hair. That is the most common complaints which occur, because it is usually the deltoid muscles which are the proximal muscles which are affected by the proximal weakness. So that usually occurs in myopathies, right? Proximal muscle weakness is very, very typical of myopathies. Lower limb proximal muscle weakness is manifested as difficulty in climbing the staircase, because that the climbing stairs actually requires large amount of force to be generated by the very sturdy thigh muscles. So that's why the lower limbs, you ask about the history, whether there is any difficulty in climbing the stairs or not. And if you look at the distal muscles in the upper limb, again you again divide that upper limb and lower limb. Upper limb, again you ask whether there is a difficulty in buttoning and unbuttoning of the shirts, whether there is difficulty in turning the lock and the opening of the door knobs. So that will be the usual complaint of these patients in distal weakness. In the lower limb, there will be slippage of the slippers, and there will be difficulty in, say, um, maintaining the posture. There may be some foot drop and all, so that will be manifested as distal muscle weakness. So that's about the motor system. In sensory system, you ask about whether there is loss of pain and temperature, which will imply small fiber neuropathy, or whether there is increased falls in the dark, that will be proprioception is defective, and this vibration sense and all this will be coming out only with the help of examination. There will be not much complaint from the patient. So that's why examination is very very important for delineating which particular sensory pattern is present in a patient. Then you have to look for upper motor neuron signs, whether there are any signs of UMN lesion. You have to look for that. Okay. And then evolution. So what is evolution? So you need to know whether it is onset. So evolution actually starts with the onset, and then how it progresses, how the disease actually progresses, that is how it evolves. So if it is an acute onset, or if it is acute onset, or subacute onset, or chronic onset. Now if the disease has begun in any of these fashions, it can either progress, it can either be a one time attack, that is a monophasic illness, or it can be multiple attacks, keeps on relapsing and remitting course. So any of these patterns will again help us to identify the disease. Then we have to ask about the family history in these cases, which will help us to know whether it is a hereditary neuropathy or not. And then you ask about the associated conditions like diabetes, amyloidosis, yeah, peripheral nerve thickenings, and all these things. So that is all the associated conditions which we'll be talking about. So these 7 key questions we need to memorize, definitely need to memorize, because the pattern recognition which we are going to study next is actually based on these 7 key questions. Very 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 important questions these are. Right now, this is the answer to the 7 key questions we asked. So based on the answers to the 7 key questions, we have got 10 patterns. Although it looks very very intimidating, but it's very very easy to understand, very very easy to understand. So first pattern is pattern 1. Now just recall the previous 7 key questions. We first asked which systems are affected. Now in the pattern 1, it is the motor which is affected, and it is symmetric affection, it is proximal plus distal weakness, and there is a non-length dependent weakness. There are no UMN signs, it is acute or chronic onset, there is no family history, and associated features, that is if there is associated CIDP, maybe paraneoplastic, all these things. So you may have evidence of malignancy. So this is basically LMN weakness, because there are no UMN signs in this patient, and there may or may not be sensory. So that is, you can see that there is proximal and distal weakness, right? Proximal plus distal weakness, and it is completely symmetric. WW indicates weakness. Now we have another pattern. This is known as pattern 2. Here we add this sensory component to it. We have LMN weakness, right? But we add the sensory component to this, right? So it is a sensory plus motor, but what is important here is that it is only the distal. That means it is a neuropathy. It's a neuropathy, right? So whenever the disease affects only distal, that suggests a neuropathy. A peripheral neuropathy, that suggests a peripheral neuropathy. So if suppose the nerve roots are involved, you will get both proximal and distal weakness. So AIDP, actually if you remember the name of these, AIDP is acute inflammatory demyelinating polyradiculoneuropathy. So radicals are affected. What radicals? The ventral roots, that is the ventral radicals which are affected. So definitely, since the radical is affected, you will have proximal plus distal weakness. But in this case, the pattern 2, what is actually happening is that it's a distal weakness and it is symmetric weakness. So it is otherwise known as distal symmetric peripheral neuropathy, or DSPN. DSPN. So DSPN is the most common type of neuropathy which is associated with diabetes, right? And as the name indicates, because it is only distal, then distal part is actually the small fiber, so it's a small fiber neuropathy. You do not have any UMN signs. It may have acute onset, it may have subacute onset, or it may be chronic onset. Family history may be positive or negative. Positive in cases of Charcot-Marie tooth, and associated will be diabetes and pes cavus in patients with CMT. Now, if you look at this third pattern, so what is this third pattern? Third pattern is involvement of discrete, nerves in different regions, right? So basically, right arm weak, right, say wrist weakness of the wrist muscles, and along with some sensory loss, and there is a weakness of the left foot. So two discrete, two different regions, two different nerves affected. So that's why mononeuritis. So mononeuritis means a single nerve. Multiplex means different areas. Multiplex. So sensory and motor will be affected because the nerves are involved directly. The nerves are involved, and it will be asymmetric by the name itself, because multiplex, it is asymmetric, and it is distal muscle weakness because the nerves. I told you that only radicals will cause both proximal and distal. Only distal means it is a nerve, and it will also involve the smaller for large fibers, smaller large fibers, definitely, because just imagine this small fibers. What are these small fibers and large fibers? They are all bundled inside the nerve fiber itself. So the nerve fiber actually contains all of these fibers, small fibers and large fibers both, and there will be no UMN signs in these patients, and definitely acute, they may be acute, subacute, or chronic. Okay, and family history may be positive or negative in these patients, and you may have associated with vasculitis or Lyme's disease. Okay, so basically you don't need to remember about this family history part. You may forget, you may think that okay, you remove it. Most important in this setting is this Hansen vasculitic sarcoid Lyme's. HIV is a very very important cause of mononeuritis multiplex. So whenever a word mononeuritis multiplex comes, you should always think of Hansen in our country. Secondly, you should think of vasculitis. Okay. After vasculitis, you should think of sarcoid. Lyme's and all, you may think, you may not think. It's not that much common. For MCQ point of view, definitely Lyme's you should remember. But definitely speaking in our country, you must think of Hansen's. You must look for peripheral nerve thickening in these patients. You must rule out vasculitis. You must rule out sarcoidosis, and also an HIV test has to be done in patients with mononeuritis multiplex. Then coming to the next pattern, that is the pattern 4, which is a plexopathy or radiculopathy. So what is this plexopathy or radiculopathy? So plexus, that's the brachial plexus, the lumbosacral plexus. You have different plexuses. So whenever the nerve roots emerge, when they emerge before becoming the peripheral nerves, they join to form some plexuses, right? So either a plexus or a radical may be affected. That is what is known as a plexopathy. Now you may ask me, now what's the difference between this and this, the pattern 1? Because definitely here also we have involvement of the radicals. The thing is, the basic difference here is that it is a symmetric one, right? It's symmetric weakness, because here the basic point is that it is demyelination, but here the pathology is a bit different. Okay, so as I had already told, the basic fundamental rule applies everywhere. Radicals, definitely it will be proximal and distal, but remember, since it is not a common pathology, it is some pathology which is kind of affecting asymmetrical. It's not demyelinating pathologies will be symmetric, but here in this case it is asymmetric. And definitely because the radical contains, it will be not only the selective involvement of the ventral roots, it involves both the sensory and the motor roots. And if you look at the type of this neuropathy, that will be sensory neuropathy, that is both small and large fibers because the radicals are affected, and there will be definitely no UMN signs. It may be acute, it may be subacute or chronic, but mostly they are chronic. There may or may not be family history, but because family history is very, very common in patients with HNPP. I will be discussing about HNPP whenever I discuss the hereditary neuropathies. This is hereditary neuropathy with liability for pressure pulses. Okay, and associated conditions may or may not be present because in diabetes and all, definitely you can get diabetes as an associated condition. So RBS, then fasting blood sugar, everything has to be done, ruled out in these patients presenting with plexopathy. Also in patients presenting with this DSPN. So pattern 2, pattern 4, definitely do a fasting blood sugar to rule out diabetes. And HNPP, do not think of it as first, definitely it is the last diagnosis. Okay, so pattern 5, what is this pattern 5? Here comes from the pattern 5 only the UMN signs will come. Okay, so UMN signs, up till now there were no UMN signs up till now. Now the UMN signs come. The fourth question comes. Here in this patient we have an asymmetric weakness, right? It is only motor system. This is a distal asymmetric weakness, distal asymmetric weakness. There may or may not be AUMN because we are discussing about say PMA or only LMN affection. See, you should never think of a motor neuron disease if it is only LMN findings, right? Very, very uncommon. But definitely you can think of ALS if you have both a combination of UMN plus LMN findings. So that's why I have written that MND is the first DD whenever you have a motor, no sensory, distal, asymmetric, UMN findings, chronic, and there may family history is very, there are different types of familial ALS. So we are not actually going deep into that. We will be discussing that separately in ALS video. So family history plus or minus, that's why I have written. Associated behavioral changes may be seen in FTD ALS, which is actually associated with a mutation which is present in chromosome number 9, and that is known as open reading frame 72. C9 ORF 72, which is associated with behavioral changes and FTD ALS. In ALS, the most common the genetic mutation you'll get is SOD, superoxide dismutase. PMA is the only LMN findings. You do not get any UMN findings. Now coming to the sixth pattern, which is combination of UMN plus distal sensory. So here we didn't have any sensory, right? Here motor is there, the sensor is there, but here this is symmetric and distal. The sensory affection is symmetric and distal, and because I have told you that the sensory affection, just imagine the first patient which I showed you, he actually fits into this pattern. See, he had motor plus sensory first in the history, then he had symmetric, he had distal involvement, distal neuropathy was there, distal weakness was also there, and ankle jerks were absent, so that again distal. Then UMN signs were positive because the plantar was extensor, and it was a chronic. In that case it was chronic, but you can have subacute because subacute combined degeneration. Family history may or may not be positive. Definitely in adrenomyeloneuropathy you may get family history, and associated conditions, definitely you will ask about the history of any ileal resection or not, and CLD and all. Hypocupric myelopathy, you may ask about history of usage of dentures because dentures contain zinc, and zinc induces metallothionein, which will decrease the absorption of copper. So that is hypocupric myelopathy. Subacute combined degeneration can occur in pernicious anemia, can occur after ileal resection. So definitely look for signs of pernicious anemia. And this adrenomyeloneuropathy, there is involvement of, as the name indicates, adrenal glands. There will be hypoadrenalism, and there will be spinal cord affections manifested as UMN findings. You may get UMN findings in this, and neuropathy, that is symmetric distal neuropathy. Let's have a look at the seventh pattern, which is only element findings. You don't get any sensory findings, only element findings. So actually, you may ask, okay, why I included this in different, why not in the fifth pattern, which has a UMN plus? Actually, if you think of this, this is having both UMN plus element. This is only element, and just imagine all the findings which I have discussed previously, 1 2 3 4 5 6, everything. There is no place where you don't have any sensory, only element findings. That is the only pattern, that is the seventh pattern. So seventh pattern is actually LMN. Okay, lower motor neuron. So lower motor neuron means what? It will be motor only, definitely it will be motor. It will be symmetric, definitely it will be symmetric. And there will be proximal or distal weakness, we do not know, because see, LMN, lower motor neuron, may be affected near the root, it may be affected. So it may cause proximal or distal, any of these may be affected. And there are no humans, and the name itself indicates LMN only, and it is chronic. Definitely you remember this point, that all these LMN only symmetric proximal or distal weaknesses are usually without the sensory symptoms. Always they are usually chronic, not acute. And there will be definitely a family history, because you can have this proximal plus distal is known as SMA. If it is only distal, it will be distal SMA or atypical Charcot-Marie. Do not remember this one, you may or may not remember CMT. Definitely remember distal SMA can actually present with only distal muscle weakness. Proximal plus distal can be affected in SMA. And if you look at this eighth pattern, which is involvement of only the bulbar muscles, only bulbar weakness. Okay, so it will be motor, definitely it is motor. Second question, you get the answer is focal, because it's only the bulbar muscles are affected. UMN may or may not be affected. And no sensory, definitely. Acute and chronic, okay, can have presentation like acute, because acute one is your GBS, acute GBS. Family history may or may not be positive, that is X-linked one, it's known as Kennedy's disease. And then ALS, you can have a bulbar variant of ALS. Okay, now this ninth pattern is actually asymmetric proprioceptive defect. So proprioception is guided by large fiber, so definitely the third question answer is large fiber. Definitely proprioception is a sensory one, so sensory modality is affected, and it is asymmetric in the name itself. The ninth pattern is asymmetric, definitely asymmetric. It is large fiber, it is no UMN findings, and it is acute or chronic. There may be family history, or family history may not be there, and it is associated with keratoconjunctivitis sicca, because if there is associated with Sjogren's, then you may get keratoconjunctivitis sicca. Now what is also here important is that if you get asymmetric loss of proprioception, always get an HIV test done. Always, just as I had told you that get an HIV test done in pattern 3, also get an HIV test done in pattern 9. Now another thing is this pyridoxine. So pyridoxine, if it is deficiency of pyridoxine, you will get neuropathy, peripheral neuropathy. But excess of pyridoxine actually leads to this proprioceptive, asymmetric proprioceptive loss, that is a ganglionopathy. These are actually ganglionopathies. So pattern 9 is actually a dorsal root ganglionopathy. And paraneoplastic conditions has to be ruled out, so look for signs of any cancers, otherwise especially the small cell cancers, so rule out those. Now coming to pattern 10, which is only involvement of the autonomic nervous system. So the first question is autonomic involvement, second question definitely doesn't come out, third question, it is a small fiber, because autonomic fibers I had already told that they come under small fibers. There will be no UMN findings. Acute GBS can have autonomic symptoms, subacute porphyrias, then chronic onset like diabetes mellitus or amyloidosis. Family history will be positive in patients of HSAN, that is hereditary sensory autonomic neuropathies. Okay, and associated conditions, obviously you'll get diabetes, or in case of amyloidosis, look for myeloma, M protein. Okay, so because myeloma is definitely the most common cause of primary amyloidosis. So basically I think after this discussion of the pattern, you can actually divide all the patients into, you can kind of recognize the pattern and try to put them in each of these patterns. And definitely once you put them in each of these patterns, you will be able to think of what to do next, what next tests to order in these patients, because each of these patterns has got very distinct causes, right? So like for example, this pattern 3, definitely you'll go for a peripheral nerve thickening, examination of peripheral nerve thickening. You will look for, ESR and all these things, constitutional symptoms, and also you may have to go for ANCA and all these things, vasculitis and all these things. So that I'm not going into detail. So that actually will help you to categorize the patients and to know which particular patients needs which tests, right? So moving on. So what next test to do? Definitely you will do a electrophysiological test. So what electrophysiological tests we have actually? One is the nerve conduction studies. So nerve conduction studies are actually dividing neuropathies into axonal and demyelinating. So whenever you get a report, you have to interpret them on the basis of motor nerve conduction, sensory nerve conduction studies, right? So whenever you get a nerve conduction study, actually when what actually is nerve conduction study? We actually apply one stimulating electrode, and we have a recording electrode. So see, this is a stimulating electrode and this is the recording electrode. So this, across the length of this nerve fiber, we actually measure the action potential which is generated by that stimulating electrode, and we record the nerve conduction velocity. So this is the compound motor action potential, okay, CMAP. If you look at the axonal neuropathy, what actually happens is that there is loss of conduction and all this. Actually you just don't think it is conduction, it's actually loss of the axons. So because there is loss of axons, the motor action potential will decrease, definitely it will decrease, and distal latency will be normal because the conduction is not impaired, because the myelin sheath is preserved. So definitely only there is prolongation of the distal latency in patients with demyelinating neuropathies. So demyelinating means always conduction velocity will be slow, there will be prolongation of distal latency, whereas in axonal you will get normal distal latency and normal conduction velocity. This you have basically, fundamentally you have to remember this, because see, demyelinating neuropathies will have affection of the myelin. So myelin is responsible for saltatory conduction. So what happens in demyelinating neuropathies? There is loss of myelin. So when there is loss of myelin, conduction is stopped. So because the conduction is stopped, definitely that will lead to conduction blocks. So you get features of conduction blocks in patients with demyelinating neuropathies. Now another feature is known as a temporal dispersion, which is actually positive in demyelinating neuropathies, which you have to remember that whenever you look at the action potential, they are temporally dispersed across the length of the nerve fiber in demyelinating neuropathy, whereas they are negative in patients with axonal neuropathy. The F wave latency, obviously, because the conduction is delayed, definitely it will be prolonged in demyelinating neuropathy. So F wave latency and H reflex are prolonged, whereas they are normal in axonal neuropathy. The same thing applies to the sensory nerves also, because they are no different from the motor nerves. So sensory nerve action potential will be decreased in axonal, whereas it will be normal, just like in the case of demyelinating neuropathies, motor studies. Distal latency will be normal in axonal, whereas it will be prolonged, and there will be slow conduction velocity in demyelinating neuropathies. EMG, definitely if you do it, it will be showing fasciculation and fibrillation, lower motor neuron type, that is in axonal, whereas it will be negative in demyelinating neuropathies. This is just a basic, very basic overview of nerve conduction studies. There are a lot of things, a lot of intricacies in these nerve conduction studies, but this is kind of a general overview. Now, let's have a discussion on the specific types of neuropathies. So, hereditary neuropathies, one of the first hereditary neuropathies, Charcot-Marie tooth disease, most common, and it is demyelinating. One is demyelinating, two is axonal. Okay, and 1, 2, 3 are actually autosomal dominant, whereas 4 is autosomal recessive. Type 1 is the most common hereditary neuropathy, is an MCQ. A lot of questions have come on this, and it usually has a distal weakness and sensory loss. What is this pattern? The second pattern, that is DSPN. Okay, distal symmetric sensory motor polyneuropathy. Okay, and you can get foot drop because there is distal weakness, so you will get foot drop. There is atrophy of the anterior compartment of the leg. Then that anterior compartment atrophy actually gives the appearance of this inverted champagne cork bottle, champagne bottle cork. That leg will, the appearance will be like this. Okay, there will be atrophy of the anterior compartment, so that's why you get champagne cork like so. Since it's a demyelinating, type 1 is demyelinating, so it is 20 to 25, conduction velocity is grossly diminished, and most common in the type 1 is 1A, which actually shows this onion bulb formation. And the if you ask me, the mutation, actually the defect, genetic defect, is this duplication of PMP22. Okay, and myelin protein Z in type 1B, which is a duplication also. In type 2, the conduction velocity is normal, and it is due to mutation in mitofusin 2. This you have to remember. Actually, you can make mnemonics, or you can remember like that itself. So type 1A is actually PMP22 duplication, type 1B is MPZ, and mitofusin 2 is type 2. 1X, as the name indicates, X, so it is X-linked, dominant, more severe in the males. Okay, and obviously because it's X-linked dominant, definitely they do not have any other copy, and definitely more severe in males. The presence of pes cavus, there is hematose, and the skeletal deformities you have to remember. And nerve conductions will show demyelination just like your type 1, because it is type 1, it's a variant of type 1. And there will be axonal pattern also may be shown in some patients. This you may remember, may not, but remember this demyelination. There is defect in this connexin 32. Hereditary neuropathy with liability for partial pulses, I have already discussed, that is presence with the third pattern, that's a mononeuritis multiplex kind of pattern, and there will be deletion of this PMP22. So this is duplication is your 1A, CMT1A, whereas the HNPP is deletion of PMP22. This has been asked multiple times, very important. Then hereditary neuralgic amyotrophy actually presents as type 4 pattern. Amyotrophy means it will be involving the proximal muscles, so definitely where proximal muscles and distal muscles will be affected, it is always the nerve roots or the plexuses. So hereditary neuralgic amyotrophy, the fourth pattern. Okay, now I'll be talking about some very rare hereditary neuropathies. You don't get much of questions from this, but Fabry's disease has been asked sometimes. The mode of inheritance has been asked. It is X-linked dominant, and it is characterized by presence of angiokeratomas, and it will be presenting as DSPN pattern, and there will be presence of cardiomyopathy, and the enzyme which is defective is alpha galactosidase. This you have been reading from your biochemistry. And strokes, young stroke, rule out Fabry's disease. Adenomyeloneuropathy, there will be UMN signs, we have already discussed the sixth pattern, and there will be increase in the very long chain fatty acids. And Tanger's disease, orange tonsils will be present, very classical. And third pattern, that is mononeuritis multiplex kind of pattern. Porphyrias, acute intermittent porphyria, variegate porphyria, and hereditary copper porphyria, they are the only three porphyrias which have presentation as neuropathies. Acute intermittent porphyria, the treatment is glucose plus heme. It is an axonal pattern, and first pattern, that is DD, will be GBS. They have a subacute onset. Okay, Refsum's disease, you get elevated CSF protein, you get cerebellar ataxia, and you get retinitis pigmentosa and DSPN pattern. Familial amyloid polyneuropathy is due to this mutation in the ATTR, and these are two new drugs which have come out, that is tafamidis and meglumine. Diflunisal can also be used, but the definitive treatment has to be liver transplant actually, but the success rate is not that much great, but it definitely reduces the production of ATTR, because the liver is the main source of ATTR product of the transthyretin production. Okay. Now, acquired neuropathies are actually divided into, very common ones. Actually, if you look at the common ones, one is the diabetic neuropathy, which is, as I told you, it is a pattern 2, that is a DSPN, or it can present as amyotrophy, that is Bruns-Garland syndrome, and autonomic dysfunction can also be there, and that is pattern 10. Mononeuritis multiplex pattern 3 can also be there. Sjogren's can have DSPN. RA can have pattern 3. Then SLE, most common is DSPN, followed by mononeuritis multiplex. Systemic sclerosis, also pattern 2 greater than pattern 3. Sarcoid cranial neuropathy, most common, that is the seventh cranial nerve. And in sarcoid, usually it is a bilateral facial weakness, and here you get the fourth pattern greater than third pattern greater than 2 pattern. So because this sarcoid actually compresses on the plexus, so you may get a plexopathy. And uremia, most common pattern is a DSPN. Rarely you can get GBS like, which will improve on dialysis. So basically you can keep in mind that DSPN actually occurs in most of the metabolic and toxic neuropathies. Hansen's also, you see, DSPN is the most common one. Diphtheria, it will have descending paralysis. Okay. Now let's have a look at the toxic neuropathies. What drugs we use, and what neuropathies they can cause. Most important drugs I have just listed here. One is the chloroquine, amiodarone, colchicine, pyridoxine, isoniazid, this dideoxycytosine, didanosine, and your lamivudine, and your stavudine. So these are the drugs which actually cause anti-HIV drugs which can cause neuropathies, and it is a DSP, and distal symmetric neuropathy, and they have this coasting effect. So what is this coasting effect? Even after stoppage of the drug, you have this neuropathy still progresses for 2 to 3 weeks even after stoppage of the drug. That's known as coasting effect. Then chloroquine neuropathy, it causes actually neuromyopathy. All these will cause neuromyopathies. Chloroquine, amiodarone, and colchicine, all three will cause neuromyopathies. That means they can cause both neuropathy and myopathy, and it is an axonal pattern. It is reversible, and you can get autophagic squamous cell vacuoles. Here it is also a vacuolar myopathy, same. Colchicine also the same. Pyridoxine, as I told you, toxicity of pyridoxine causes ganglionopathy, but deficiency will cause a neuropathy, as occurs in isoniazid toxicity. So this isoniazid toxicity is axonal. The toxic neuropathies, mostly they are axonal. Okay. And slow acetylators are at increased risk of pyridoxine deficiency. Okay. So that will that give them pyridoxine supplementation. And glue slippers neuropathy is due to these hexacarbons, and it is a mixed one. This is the only thing which you have to remember, that it is the only one which has both features of axonal and demyelinating. Let the most common presentation will be encephalopathy, and this pattern you have to remember, wrist finger extensors are affected, so you can get wrist drop. Okay. And the autonomic nervous system can be affected, and this basophilic stippling occurs, and coproporphyrin levels are increased in the serum, and there will be reduction in the compound motor action potential, because it is an axonal neuropathy. Mercury, you will get minimatus disease, that is ouch will be there, so that is paresthesia will be there of the hands and the feet. Arsenic, you get pattern like your GBS, and it occurs after ingestion of arsenic, acute toxicity of arsenic. Chronic toxicity, you will get these Mies lines, and I have written the same point here also, that is all toxic neuropathies are axonal. Now let's revisit our old case of this gentleman who actually had anemia on clinical examination. We had pallor. So we did a CBC in that patient. So we got macrocytic anemia. His anti-intrinsic factor antibody was positive, that is pernicious anemia. Nerve conduction studies shows axonal pattern, right? And there is both sensory and motor axon cmaps are reduced. Cmap is reduced, conduction velocity is normal. MRI showed a rabbit ear sign. So this kind of affection, that is, it is involving the posterior columns as well as the lateral corticospinal tract. And methylmalonic acid and homocysteine levels in the serum were increased. Now definitely there is only and only one diagnosis. It is SACD pattern 6. Pattern 6. How do you treat them? You give parenteral supplementation of vitamin B12 because vitamin B12 is not being absorbed because there is anti-intrinsic factor antibodies. So give 1000 micrograms of cyanocobalamin IM weekly for 1 month, and then you give it every monthly thereafter. So with this, I think I have kind of covered most of the causes of neuropathy, the pattern recognition of neuropathy, and general approach I have actually discussed in this video. And I hope this video will help you to treat a number of patients of neuropathy, actually identify the cause and treat them. So thank you very much for your patient listening. Actually this has become a very long video, but I think it's worth it. And thank you very much for again for your patient hearing, and subscribe for more updates on neuromuscular junction disorders. The next video is going to be on neuromuscular junction disorders. So thank you very much.